Hello and welcome to another edition of the Osteopathic Lyceum podcast. I'm going to talk about something a little bit more conceptually here. I don't absolutely have a bunch of information previously found by other people to point to say that I'm correct. So essentially what you would call this is a hypothesis with respect to multiple lines of observation. Please excuse me as I clear my throat. So, one of the reasons that this topic came to me is because I was doing a demonstration trying to show how to do a temporal sway or temporal swing. There's different names for it that I've experienced, or my memory sucks. I'm not sure which one. But anyways, you're at the head of the table with a supine patient and you do a general cranial listening hold. So your hands will look a little bit like this. Your fingers are splayed, and your two middle fingers, where you would make the V for the live long and prosper, as in Star Trek, the Vulcan V, you will be around their ears, so you're not squishing their ears. And then usually your ring finger will be on the mastoid process of the patient, the mastoid being part of the temporal bones. You're going to attempt to identify which one of the temporal bones is not moving as well as the other one when you apply pressure there, with the concept being that because you're pushing the bottom in, the top will pop out, relating to the Sutherland, the William Garner Sutherland, or W.G. Sutherland approach of working on the gills of the fish, so the articulation between the temporal and the parietal bones. So you're trying to work on that by pushing on the bottom. Now, because you have to put pressure on those, and it's one finger, very generally speaking, and you're holding, one of the things that happens is you're going to have some neurological phenomenon. You're going to generally feel your finger. You're generally going to feel your flexor tendons in your forearm, around your wrist. You're going to have these interesting sensations. And because you were holding something for a little while, when you're done and you retest, neurologically, you're able to observe that you feel different than when you started. So the simple question is, if my pretest was squishing the mastoid in on both sides, one side then the other, or both sides at the same time, and attempting to identify difference, and then I have to hold the one that's not moving based on what I think my finding was, am I sure that because of the difference from holding, that when I retest with that ring finger, that I'm actually detecting difference in the person or in my sensation? So fundamentally, what it allows me to think is that most often what you're going to have to detect is some difference in sensation for you as the observer. If that is with something that you have applied pressure to for a period of time, I think it's harder to trust that your test-retest reliability is as good as you would want it to be, because your measuring device is essentially a little screwy or a little fuzzy, the measuring device being your hand. Whereas with respect to test-retest validity and visual stimuli, or primarily visual stimuli, it's probably a little bit more accurate. So when you're looking at how far things move versus feeling how far they move, I think it's possible that you're going to be more accurate. So my hypothesis, simply stated, would be that if you're testing and retesting more with visual stimuli than tactile or palpatory stimuli, you're probably a little bit more likely to have a higher amount of accuracy visually than with tactile senses, especially if the intervention was performed with your hands. Let's just say you didn't have to put a lot of pressure on your hands to work on an area, then in all likelihood it's fine, because you haven't altered the internal sensation of yourself on your hands. So when you retest, your hands feel like they did the first time. But if you've been holding something with your hands and putting pressure on it with your hands, your ability to retest may be limited because your hands just feel different, whereas your eyes don't. So, maybe to amend it, if your test and intervention require pressure on your hands in a very similar manner, so the move that you test with your hands is the same as the move that you have to apply pressure with your hands to treat and then retest, you may have test-retest reliability issues, whereas your eyes are unlikely to suffer from that same phenomenon, which allows us to try to figure out possible ways around that. So one of the ways around that. Now, before I do that, I should admit that it's a hypothesis. So it's a prediction that can be tested. So one of the ways you would test that is you would have a move, say temporal sway or temporal swing, whereby the person identifies with their hands the side that they feel is more restricted, and then you have some measuring device that is not hands and is more objectively reliable to attempt to apply pressure and measure what the heck happens. Then, and I don't know that there's a device like that. Then what you would do is the person would apply the treatment and then retest in the same way. So essentially you have the phenomenon whereby if there's a neurological difference because you're feeling your finger, you're feeling your forearm flexor tendons around your wrist, you're feeling a difference because you have to hold, and then you retest, and then the machine retests, and then you make your claim and the machine checks your claim. If the sensation that's different in your hands doesn't do anything to your accuracy, then perfect. If it does do something to your accuracy and you're less accurate and it didn't change, but you think it changed, then the machine checks that. So essentially, if the prediction is correct, we can see it. If the prediction is incorrect, we can see it. The prediction is that it'll actually change your accuracy. So what we would want to see to support that would be that you inaccurately state that there's difference in movement, and the machine says there is no difference in movement. So that's essentially what we would want to see. So it can be tested, and then if it was tested, which I don't necessarily have the current resource or opportunity to do, what we would learn is that it's useful to engineer tests that don't rely on the same thing under sustained pressure because of the human sensory system to retest. So the tests that I happen to prefer are larger tests, and the heuristic that would point you in that direction for my preference for them, as well as when you observe my teaching and my YouTube videos on assessment, is macro identifies micro. I prefer big movements that are comprised of smaller subunits, and when the big movement doesn't work, the smaller subunit is usually visible. That test means that I don't have to rely on my hands falling prey to neurological sensory tricks and then making claims when my hands are in a subpar position to retest. So I don't know that I'm right, but I know that I have a prediction that I'm going to trust my eyes more than I'm going to trust my hands that may be numb. So let's just say you consider something like craniosacral therapy or even osteopathy in the cranial field and an over-under hold, or a hold where the hands are stable for a long time and underneath a piece of anatomy. So the head isn't as bad, but if you have to hold onto the temporal bone, or if you have to do, say, you want to try to split the sagittal suture and your fingers are crossing, or you're lifting, or you're pushing, whatever it is, because you have to maintain pressure for a while, you're prey to sensory changes in your hand. If you're doing an over-under hold, you have one hand on the sacrum and one hand on the pubic symphysis, then the hand under the sacrum is squished for however long. I think that hand is probably going to have some level of occlusion for blood flow, some level of impact on that neurologically, so pins and needles, things like that, such that trusting it to retest the same way it tested the first time is probably not the smartest idea. So my general preference is tests that don't challenge the device that's testing it. And by device, it could be your hands, it could be your eyes, it could be your ears. I prefer tests that don't challenge it or change it in a sensory manner such that my test-retest reliability is reasonable. So this all comes from describing the experience of doing temporal sway or temporal swing to students and saying, well, I don't know if it's different because my finger has had pressure on it, my forearm flexor tendons have a lot of sensation around my wrist, right? So I don't know if I trust this retest. This all comes out of that. Now, the reason I want to communicate this on any level is because this was something that was inside my head and not necessarily coming out explicitly such that I could communicate it to people in a meaningful way so that they could then use it. What really was happening is I had some tacit or implicit understanding of it that I never figured out how to communicate before. But now I seem to be in a better place to communicate that. So I might as well do it while it's fresh in my mind and say, if you're challenging the sensory device that you're treating with, that you test with, then you treat with, and then you retest with, if you're giving it a sensory challenge, you might not want to trust it on the retest as far as being accurate. you might want to use different tests to figure it out. Now, the kind of wiggle on the mastoid process may be reasonable if there's another test I found it with first. So if there's another way I found that, let's just say it's blunter, but like I squeezed with my thenar, the thenar portion of my hands, I kind of squeezed the mastoids there, and I did it in as even a way as I could. And then I went to that general listening hold and I used my ring fingers, and then I retested with the thenar squish. Maybe that's more reasonable because my thenar eminence is a little bit more blunt, a little bit less sensitive, but maybe less impacted temporarily by the holding with the ring finger. So the superficial example there is to say that the area of the hand that I would test with and then treat with is different. So the area that's testing is less subject to sensory disturbance or sensory difference. So trying to communicate this out loud explicitly, because I seem to have been put in a position in teaching where I can take something that's implicit, that guided the choices that I made, that guided the way that I attempted to develop curriculum and communication implicitly, but now I can make it explicit, I can make it more clear. So my preference for using large motions and vision to identify stuff is often predicated on the fact that I would have thought, but not said, that the hands are subject to sensory change way more than the eyes are in most circumstances, such that the eyes can be, say, the final check or the more consistent, reliable check on stuff, versus the hands, which when you're testing with a part of your hand and treating with the same part, you could trick yourself when you retest it that way. And that can be considered or predicted to be an issue. So I think I had a prediction that I wasn't able to verbalize before. Now I'm verbalizing it. Thank you for sticking around through this. Hopefully you learned something from it, and hopefully you're following along on the journey and understanding that I'm working this out in an iterative sense to try to make things better. So thank you again for listening, and we'll talk again soon.